My name is Terry Mamounas. I'm the medical director of the Comprehensive Breast Program at Orlando Health Cancer Institute in Orlando, Florida. So that is a very important question that patients ask. How do I know that my cancer is gone and now that I'm finished with chemotherapy, surgery, radiation for early stage breast cancer? And how we counsel the patients for this question is that in general, we believe that the patient at that point is disease-free, at least from a clinical standpoint of residual tumor. We don't have any evidence of the tumor. Depending on the stage of presentation of the patient, we may have done staging studies looking at the bones and the chest, abdomen, and pelvis, or sometimes PET scans. But usually for the early stage patients, stage 1, stage 2, we don't do much of these staging studies. We assume that the patient doesn't have metastatic disease because it's very uncommon to have metastatic disease at that point. But patients ask, how would you monitor me in the future? How do I know the cancer may come back? And the answer to that is a little bit complicated. In general, the guidelines suggest clinical examination, bilateral mammogram, obviously, if they have the breast once a year, clinical examination every 2 to 3 months in the first 2 or 3 years, and then every 6 months for up to year 5, and then typically annually after that. And with these exams, we obviously look at the local regional areas. We check the breast or the mastectomy site, the axilla, make sure there's no change in the physical exam. With a mammogram, of course, we're looking for new primaries or in-breast recurrence in the breast. But we don't do elaborate testing, and I emphasize that to the patients, that we don't necessarily do CT scans or PET scans every year, because first of all, there's a lot of radiation involved with this test, and the probability of finding something at any given year is actually very, very tiny, unless you have a huge risk because you presented with a very advanced breast cancer, but ended up having sort of adjuvant systemic therapy and surgery. So in general, we monitor these patients with routine blood works to make sure we check the liver enzymes and the bone enzymes. Even tumor markers, such as, for example, CA2729 or CEA, are not recommended by the guidelines to serially monitor for recurrence. They're better to monitor if the patient have advanced disease to see response to therapy, but for the early stage setting, we don't use these biomarkers. There is a lot of research that's going on right now trying to identify blood biomarkers, such as, for example, circulating tumor cells or circulating DNA. This is still not considered the standard of care and is still in the experimental phase, but there may come a time that we can monitor patients with these biomarkers if we show their clinical utility in detecting early recurrence, and more importantly, that we have to show that if we then intervene at the time of a biomarker increase, if that affects then the outcome of the patient, that becomes a useful biomarker to do in the future. But if that tells us that the patient just will recur in the next 6 months and you cannot prevent this recurrence because the biomarker became abnormal, then you haven't really done anything to extend the life of the patient. You just know that this is coming, let's say 6 months earlier because of the biomarker. So we follow patients, as I mentioned, just with clinical exam, with bilateral mammogram, and of course, during these visits, if they have any symptoms that they mentioned, then we work the symptoms individually. For example, if they complain of a persistent bone pain in their back, then we'll obviously do appropriate tests to document there is no bone metastases that come from the breast cancer. So that's typically how we follow patients and handle the issue of how do you know that the cancer is gone.